We now come to the last lecture for today. That is Dr. Avnindra Gupta who is going to talk about his approach to extra large macular holes. As Lalit said, we've all talked about small holes, but what we see more often are the bigger ones. So let's see how to manage them.
Thank you, sir, and good morning, everybody. The basic concept is ki with all of us, ki if you have a large macular hole, then this cannot be operated. You will not get any kind of results. But with this technique, with the advent of newer technique, we are able to close these holes with a decent gain in vision. What a large or giant macular hole is defined as base macular diameter of 1000 microns and MLD of 800 microns. These holes have high rate of failure, and the failure rate is in between 650 to 1416 micrometer is between 19 to 24%. If you look at the closed classification, which is a recent classification, according to the size, the classification has been given. Large macular hole is between 400 to 650 microns. Extra large macular hole is 650 to 800, and large macular holes is 800 to 1000, and above 1000 micron we label it as a giant macular hole. And with the advent of OCT, we can measure this and we can prognosticate our patient. These are the management strategies for large giant macular holes. So our concept is to provide a scaffold with an inverted flap or an ILM graft, and retina is made elastic by detaching it in macular arcade. Now, if you look at this patient, it's a giant macular hole. And if you look at the base diameter, it's somewhere around 1100, and the minimal diameter is 800 microns. So we go ahead with the surgery, which is with ILM flap with macular hydrodissection. Once you do an posterior vitreous detachment, and the ILM is stained with the BBG dye. Then a rip is created with the help of a diamond dusted membrane scraper. And since I want to make an ILM flap 360 degree, a good flap is important for the closure of the macular hole. So I create this 360 degree rip with the help of a diamond duster, because with this technique I'll get a very good macular flaps. The rip I continue on the temporal part, and you can see here almost 360 degree I have created a rip in the ILM flap. Once this 360 degree rip is created in ILM flap, I take hold of the forceps, peel the ILM, and you can see I have to peel this ILM and come just near the whole macular hole. If I go beyond this, my flap will get dislodged and I'll get a free flap. So you have to peel this macular hole till the edge of the macular hole. That should be very clear. Once this peeling is complete, you decrease the suction of the cutter to somewhere around 50 and trim this flap. Since it's a large macular hole, so what I do, I prefer to create a macular detachment. This is a 40 gauge needle on a 23 gauge cannula, and I reduce the PSI and inject BSS in the macular area. You can see here the blister, but still the detachment has not gone up till the margins of the macular hole. So this detachment is increased, and once the detachment reaches, that means I have created an elasticity in the retinal tissue. Similarly, I have to detach the inferior part also. You can see the blister here, that starting a detachment, and I can tell you it's not easy to detach an attached retina. It's very easy to say that retina detach ho gaya, but detaching an attached retina is difficult and it takes time. Once this procedure is done, I go ahead and do an fluid air exchange, and you can see the post-operative results. This is 2 weeks post-operative result. The macular hole is closed, and this patient improved from finger count to 624 vision. This is another patient, and I started this technique with this patient. You can see a silicone oil filled eye, almost a square shaped macular hole. The chances of closure are pretty less. So what I do, I go ahead, remove the silicone oil, put BBG and create and rip an ILM flap, and then an ILM flap is created. Once the ILM flap is created, the flap is then trimmed, and I aspirate the subretinal PFCL from here. And what I did, in a mistake what I did here was I started detaching from the infratemporal quadrant. So once I start detaching from the infratemporal quadrant, that detachment extends to the infratemporal part of the retina and doesn't comes, the macula does not gets detached. So again, I go here and detach between the disc and the macula, and I then create an macular detachment in this area. And you can see the post-operative result. These are the post-operative results. Patient improved to 636 vision with a very good closure of the macular hole. This is one of my patient. You can see it's a pretty large macular hole with a base diameter of somewhere around 1800 microns. And already ILM peel has been done. These are the margins of the ILM peel which has been done. So what I do is I create an ILM hinged flap nasally. Then I put a PFCL and then drag this ILM flap into towards the macular hole and stuff this macular hole with an ILM flap. Then under bimanual irrigation aspiration, with one hand I am removing the PFCL, the other hand I am putting a colored BBG dye or viscoelastic. Because of the current of the fluid, this flap can dislodge, and then I create an macular detachment in this patient. And this patient, you can again see the vision improve to 624. This is one of the patient of square-edged macular hole. We did a similar procedure, vision improved from 660 to 612, and you can see how beautifully the macular hole is closed. Another patient, traumatic macular hole, a very large macular hole. This was a young patient. We used silicone oil as a tamponade, and again this patient improved to 624. These are my 9 patients, what I have done over a period of 2 years, and each and every patient had an improvement in visual acuity and a closure of hole. Various techniques has been described for failed, recurrent, and giant macular hole: inverted flap, autologous ILM transplant, lens capsule transplant, neurosensory retinal grafts, amniotic membrane graft, retinotomies, and hydrodissection. So what I do in these cases is I do an autologous ILM transplant with an hydrodissection. So the basic concept is I combine 2 techniques to get the best of the results. Up to 39% of chronic macular RDs have been reported to have adhesions between the retina and the RPE, contributing to difficulty with hole closure. This gives square-edged appearance on OCT in contrast to puckered edges seen in acute macular holes. Advancement of macular tissue by increasing the elasticity of the ILM peeling, scaffold over the macula, and macular detachment results in improvement in vision in almost all the cases. Vision improvement in all cases and can be done in traumatic macular hole. Procedures like retinal grafts and retinal refining does not result in vision improvement. Although with the retinal grafts, you are able to close the hole anatomically and you can show on OCT that yes, the macular hole is closed, but vision does not improve in all these patients. With this technique, I am able to get a lot of vision improvement in almost all my patients. The advantage of this disadvantage is I have done only 9 cases. Need more giant macular holes to come to conclusion about the effectivity of this technique. Thank you very much for your kind attention.
Thank you, Avnindra. So after you've done the detachment, you leave it under oil or you leave it under fluid, under air?
Gas.
Or gas? Okay.
Yeah, excellent technique, Dr. Avnindra. Just as a modification or an alternative to this, what I usually do is, as he showed these, it's not just large macular holes, it's large chronic macular holes, some of them that he showed, that makes it even more challenging. And what happens is this edges, why they are square is, the RP there is also a little damaged and they have got adhesions. So, detaching those and freshening up that area is a little important. So as a opposition to this, what I do is instead of, creating multiple areas of, punctures with the 40 gauge, I sometimes use the cutter and just use a gentle reflux at the macular hole side, because it's a large one, not going and damaging the RP directly, but with a little reflux, that little edge will just open up like a flower bit. And then what I do is, as opposed to a single flap, I would do multiple 360-degree multi-layer flaps over each other. So what this does is, it's not, what all these inverse ILM flaps do is they offer a scaffold for the natural progression of this coming together centrifugally of the edges. So that plus that little detachment and clearing of the debris there helps in closure. And again, I use long-acting gas in these cases, C3F8 rather than SF6, and I've had similarly.
So what I
very good
find is
results.
that in these very large holes, and very often these are myopic holes, see, basically in any macular hole, it's a capillary action which is keeping the retina attached to the underlying RP. So if you just gently brush it, even with an old, very old diamond dusted scratcher, and you basically have to remove that capillary action, they will start opposing each other. Once you see it's opposing each other, what you'll see is, in very large holes, there'll be some gap left over.
It's a macular massage, or the
Yeah, it's
massage
a very
technique.
gentle
You could do it,
massage
yeah.
with a silicone tip.
Yeah.
And then you see that there'll be some defect still left over. In fact, if there's no defect left over, you don't even need to bother about all this. It will definitely attach. The macular hole will close. But if a little defect is left over, that's where these multiple ILM flaps come. And I would actually, in these situations, prefer to put silicone oil.
Okay.
Because by silicone oil, the risk of that flap moving later on goes down.
As
Gas
the only
has a
thing is,
better
gas has a
tamponade.
very good
Gas has a
tamponade.
better,
Yes,
It's a
but-
stronger tamponade. I would just, for this very same thing, to address this instead of oil and, doing another surgery later, I would put, viscoelastic. So that stabilizes that. If you're worried that, so when they are hinged, they will never displace. That is one. But if you are, even he showed one thing about the free flap. So I don't like using
They don't
PFCL
stay.
because, when you're removing that PFCL, the flap can go off.
Yes.
So what I would do is, if I'm doing a free ILM flap, I would, get the flap, okay, bring it under PFCL, but then put visco there, stabilize it with the visco, and then it doesn't matter, you can leave the
Anand,
visco.
what I did was, with one hand, I was removing PFCL and I stabilized the flap within viscoelastic.
Yeah.
But
See, even visco
until-
is not foolproof.
Yeah.
yeah, it's not foolproof, but
other-
that is the only way where we
See,
can stabilize
the problem
the
is
ILM
a
flap.
hinge flap, which is hinged on the periphery part of the retina, is not hinged on the hole.
It's gonna be hinged at the hole
Has
only.
a tendency to move off. But if it's hinged on the edge of the hole, those stay where they are.
Yeah, they always
So the-
hinged at the, so you're
Yeah, but
flipping
if
it
you have
towards
a,
the
if
whole
you,
side.
that area has been removed and this is a recurrent hole,
Recurrent,
then
yeah.
you have to hinge it from the
But then
peripheral
it's a free-
retina.
free flap, then it's a
Those
free
have a
flap.
tendency to
it's a
move
free
off,
flap.
and silicone oil holds it better.
Okay, I'll just add a word about additional agents that can be used, because these all techniques are very traumatic. Inverting the whole flaps and these coming out, again you're going in, massaging, bleeding, and you may cause a lot of damage. So less traumatic would be to put in fibrin glue over that area, though personally I haven't done it, or platelet-rich plasma, which I have recently started using with very good result, platelet-rich plasma.
Yeah, one patient, I did a fibrin glue, but it happened to fail after that.
Yeah, that's
So,
true. So I have not used it myself.
I happened to use
So-
because I had a glue in the OT, so I thought I'll put a fibrin glue, but it didn't close.
I think, as you can realize, this is a controversial topic. Lots of ways of doing the procedure. All of them work anecdotally, but long term, we still don't know which is the best. So you've got a lot of thinking to do. With this, we close this session. Thank you very much for all of you for being here. Your presence has made the session successful. And Dr. Lalit Verma, I think, had designed a very well, it was a very well designed course with very important topics, and I'm sure you enjoyed it. Thank you very much.